Hello, everyone. I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in healthcare IT. Today, we have a really interesting guest that I think is going to educate us on a lot of really important topics. And our guest is Dan Miller. He's founder at Spora Health. Welcome, Dan.
Hi, John. Thanks so much for having me.
Yeah, so we have some really exciting topics today. But before we dive into that, tell us a little bit about yourself and Spora Health.
Yep. So starting with Spora Health, we are a primary care platform uniquely designed for people of color. And I came up with the idea for Spora Health in 2019, where I was thinking about what was next for me and looking at opportunities that I was uniquely positioned to try to solve. And having been a technologist my entire career and working on digital health solutions for the larger part of the last decade, I was looking at problems at the intersection of healthcare, but also that were really sort of focused on increasing access and serving specific populations. And I was seeing an uptick in demand for some of these culture-centered solutions, these population-specific solutions, really in mindfulness and meditation products initially. And so when you think back to 2019, odds were that if you were going to, download a mindfulness and meditation app or use a guided meditation, there was going to be a British or Australian accent attached to it, and the guided meditations weren't going to be terribly, really culturally relevant. But there was a significant, uptick in demand and folks and consumers that were looking for these types of solutions, specifically Black Americans. So that was really what started the sort of thought process about these culture-centered tools potentially.
Interesting.
And then I pivoted to looking at primary care and zooming out and thinking about, okay, so if culture-centered care is a compelling thesis, like how large could it be? And then arrived at primary care as being a really amazing intervention point to integrate culture-centered care and then start to hopefully address inequities and disparities as a product. And when I looked around the market, it seemed like this trend was also showing up in primary care solutions that were entering the market. And so, when you look at companies like TIA, Iora Health, Costa Sano, arguably these fit in this category of culture-centered care and being designed for specific populations, and not just representation in their panels of providers, but integrating the expectations of these populations, these cultural, social, linguistic expectations into the care models and into the actual experiences that these patients are having. But when I looked around, there wasn't anything that existed for Black Americans or BIPOC communities broadly. So I thought I'd build it. And I put together a team and brought on board our first physician, who's an MD, MPH, a data scientist, and our head of population health. And we worked to get the practice and the business off the ground throughout 2020. Thankfully, we had significant support. And silver lining is some of the hardship that took place across 2020 was really a lot of support and a lot of attention towards inequities and disparities. And so that provided some tailwinds for us to continue to grow throughout the year.
And is your solution just a telehealth primary care solution, or do you have actual physical offices as well?
We are solely virtual, but we do have, and we are a practice, should mention that. So all of our doctors and providers, they join our practice, but we do have relationships with some in-person clinics in some regions as well.
Gotcha. So let's talk a little bit about this, because I think it's probably a topic that many of us don't fully understand. I know there's a number of studies that have come out that have shown that that Black patients that have a Black doctor actually receive better care. Why do you think that is?
Well, I think it's I think those studies are producing those results because of the state uh, of the healthcare system in the United States. And another way of saying that is that because culture has not been incorporated in thinking about how to design care models and to reach certain populations, and also accrediting bodies aren't requiring cultural competence or health equity.
Mm.
Um, this is the system that has been designed a certain way that is producing inequities and disparities. And I'm not suggesting that the system has been designed explicitly to produce inequities and disparities, but the reason that inequities and disparities exist is because they're a byproduct of the design of the system that we're interacting with. And so I believe that race concordant care is producing more trust and better health outcomes, specifically for Black Americans and BIPOC communities broadly, is because that is a solution that works today to allow people to facilitate, that's producing more trust in the clinical encounter, which we know there are high correlations between that and medical adherence and compliance, which we know there are high correlations between that and then producing better health outcomes. And so I think it's a short-term solution that is only working in relation to the system that we find ourselves in currently. But I most certainly don't believe it is the solution. It is a band-aid for the broken primary care system that is producing inequities and disparities. There's a lot more work that needs to be done to really produce equitable access to care, equitable utilization rates, and thus health outcomes.
Yeah, I mean, we could talk about primary care issues, for everyone, but let alone the divide as well. But I think you said something pretty interesting. You talked about the trust that was created between, a Black patient and a Black doctor that's different. Is that really the big difference that, your primary care solution that's focused on this can help create? Is that trust, or are there also like different requirements and needs of people of color that the current primary care system just doesn't understand, or that doesn't appreciate the nuances there?
It's most certainly both.
Okay.
And trust and communication, not suggesting that you did this, but I just want to highlight that it often gets mentioned as just trust or just communication, and these things they shouldn't be marginalized as if they're just as if they're easy to correct. These are deeply rooted behaviors that are reinforced in the clinical encounter and outside the clinical encounter. And so it takes a concerted effort to change that behavior, not just on the provider side, but the expectation from the patient side as well. I just want to make sure that is clear.
Yeah,
but
that's a great
also
point to
that
highlight.
there are very specific nuances to ways in which um, symptoms present themselves within our population. So it does extend much further than just educating our providers on communication, verbal communication, nonverbal communication styles. An example being specifically for Black men, um, uh, depression as a symptom. Symptoms of depression are expressed differently than within white males. Just as comparing the two
Interesting.
populations. And so typically within Black males, depression is expressed somatically more than in white populations. And so there tends to be consistent underdiagnoses for depression amongst African American males for this reason. And this is just sort of educating our providers on one specific sort of dynamic, mental health for our population. But if we ask why that is the case and we dig back, it starts with the populations that are being included when we're thinking about designing care models, when we are, this extends into um, clinical trials as well. Historically in the United States, there just hasn't been as much of an effort to make sure there's a normal distribution of these populations as a default for designing these sorts of dynamics in clinical encounters in these care models, as well as the standardized protocols. And that's the core that Spora Health is changing, and which we focused on intently for our population. Now, I think culture-centered care is most certainly something that has benefits for all populations and all individuals, but we're focusing on people of color as it's most acutely impacting them adversely right now. And so we start here, and then we can continue to learn and grow from there.
Yeah. I just think of a previous interview we did with Visual DX, and they talked about their AI learning model that would take a picture of your skin, and to help you to diagnose, some skin conditions. And they talked about, some of what you just talked about as far as incorporating people of color, since the skin discoloration or other diseases present themselves differently on Black versus white. So I mean, it's interesting to see, that was kind of one of my first exposures to this, right? And the need and understanding of, that, hey, it presents differently in people of color versus, white people as well. So, and interestingly, they were training it into their AI, which, talk about the implications there, right? As we continue to improve technology and use AI, to your point, if the clinical trials aren't done with the right diverse population, then we're going to have some major problems, since those often drive much of the solutions that come.
Precisely. Dermatology is a very great, clear example and use case. Additionally, artificial intelligence, machine learning, clinical trials, huge implications for the sample that's being used when we are designing these programs in the onset or training the models. And they need to be protocols, I believe, for the sample that's being used to train these models in relation to the population that will be using them as an end user, whether it be commercially or otherwise. Because like optimizing for the best results, but using a sample that's not representative of the folks that will be using it either in the market or in research studies doesn't benefit anybody.
Yeah, absolutely. Do you think, I mean, it's interesting. I mean, I think you've made a pretty clear, example of why it's more valuable for a person of color to treat another person of color, both the trust and communication aspects and some of the treatment protocols. I mean, one, I don't know, I'm just trying to think, as I look this going down, are there enough people of color to take care of all the people of color and their needs, or do we need to train some of the white people, or other other ethnicities to be able to understand this? And is that even possible, to be able to help make them culturally aware? Because that seems like a challenge too, is scaling to the problem.
Well, yeah. So again, I mean, although that it is empirically true that race concordant care, specifically for Black populations, is producing better health outcomes, more engagement. Again, I believe that's a short-sighted solution, and not something that is solely representative in the panel at Spora Health. I understand that it is. The research indicates that it works, but to your point, race concordant care doesn't scale. Also, that's not the foundational issue. The foundational issue is that we don't even think about health equity and cultural competence when we are accrediting providers in the U.S. and our doctors, and there isn't enough emphasis on this type of training throughout med school or in programs that providers are taking before they become credentialed. And that's the root of the issue, is that we're not even thinking about standardized protocols, care models, et cetera, in this way, in a way that is incorporating culture specific to populations. And so you can strip, frankly, ethnicity out of it, um, and really think about culture from an environment perspective, and thinking about socioeconomic factors like household income, location, education levels. Um, and that's, like there's more overlap between our patients with those socioeconomic factors than solely than I argue would that's really driving access, and then ultimately utilization and outcomes. Now we most certainly have providers in our practice that are not persons of color, and that's been intentional. We most certainly have developed the Spora Institute, which is our cultural competence training program, because we are filling that gap that doesn't currently exist to help educate providers in the United States on how to meet these expectations of different populations, different cultural populations. And so we think we're doing a pretty good job at it. The Spora Institute currently has a 100 NPS score from all of our providers.
Wow.
All of our providers are demonstrating a 96% knowledge gain. So we assess them. We provide an attitudinal assessment, as well as assessment on cultural competence before the Spora Institute and afterwards. And they're demonstrating that 96% knowledge gain, which is significant. And our curriculum is evidence-based, rooted in behavior change, and it's required by all of our doctors and providers before they onboard onto our platform. So they have a minimum of at least 10 hours of health equity training by completing 6 modules. But there's an additional 7 that we ask them to complete after they actually onboard and start seeing patients as well.
Wow.
And we believe that it's not just something that's closing the skills gap for our providers, but it's also translating to a markedly better experience for our patients. So our patients are giving us an 86 NPS score for their experience. The industry average is 38. In September alone, we're currently in October. In September alone, our NPS was 100. Wow. And our patients are also letting us know that they're not experiencing traditional dynamics that show up in the clinical encounter that we know lead to inequities and disparities. And so we think that we're doing pretty good, and it's rooted in the training, and it's not solely because we're providing access to race concordant care. It's because we're providing access to culturally competent care, and there's a difference there, and it's not rooted in the ethnicity of the provider. It's around the training that the providers have to meet the cultural expectations of a specific population, and that's what I think needs to be focused on, and the solution that I believe is needed to really start to decrease some of these inequities and disparities in primary care.
Well, I think that's the challenge, is that we'd love to have training like this available to, in the medical schools. But I've seen firsthand, they don't give business training. They don't give tech training. And everyone said, yeah, they should. And everyone I've ever said that to or talked to about that, they said, yeah, but they never will, because there's not room. They actually may have a chance with cultural training, I think, even more than business and tech. But, to me, I would argue that maybe the bigger opportunity is once they're out of med school, just because med school is such a microcosm of so many things they have to learn. So do you offer this training to other organizations to be able to do it, or is it just for your doctors?
It is now available for other organizations. We've used our practice as a sandbox for the last year, and we feel very confident in some of the outcomes we were able to drive. So it is available for integration through other provider networks, payers. We've created a Spora Institute for Business product as well for benefits managers and HR
Wow.
folks more broadly, so that they can better understand the lived experiences and some of the inherent challenges that their BIPOC employees may have when they're interacting with the healthcare system, so they can better then vet solutions to incorporate into their benefits. And so this is available for a range of different organizations and individuals. And we're super excited about it.
That's awesome that you make it available. So are there some other biases? I mean, let's give them a flavor of what, why should they come in and purchase these trainings? What are some of the biases you find as your Spora doctors go through these trainings?
Well, I mean, as I mentioned, we assess them at the beginning around cultural competence and attitudinal assessment before the Spora Institute and afterwards.
Okay.
And so we tend to see folks making significant gains as it relates to verbal communication, maternal mortality, and trauma-informed care. And these are specific dynamics and modules that we focus on because, again, organically, they're already showing up in the clinical encounter and are leading to inequities and disparities. And so specifically, when we talk about verbal communication, we focus on this because empirically, in a clinical encounter, when a white provider is interacting with a Black patient, they tend to talk more than when they're interacting with a white patient. And so this tends to leave Black patients leaving that encounter objectively having less time to ask questions, discuss treatment options, talk about their symptoms, et cetera. But also, they leave that encounter feeling that they had less time and feeling less of a connection with the provider. So there's less trust that's developed during that encounter, which we know then leads to less compliance, medical adherence, and worse health outcomes.
Right.
Similarly, when we think about trauma-informed care as a module, sometimes as it relates to our population, patients may withhold information or refuse services due to trauma. And so we've created a module around this because we want to establish awareness that this is something that is evident for our population. And then we give our providers the tools to sort of overcome that. So those are some of the, I won't call them biases, but sort of when we assess them at the beginning of the Spora Institute, some areas of opportunity that we can make the most impact.
Nah, that's great. I appreciate you sharing that. So, I mean, the education piece makes a lot of sense. And actually, I think the culturally competent care makes sense as a direct primary care, subscription model. And interestingly enough, this is a question that I ask all direct primary care, but I'm kind of interested in your take on it, especially, given your specific focus to people of color. But will this, kind of direct primary care subscription model that Spora is doing, I mean, outside of the training, of course, your primary care business model, is it going to be able to scale to the need? And I kind of ask it, and I ask this of all primary care. It's like, is this just a rich person, model, or can it scale to everyone that needs this kind of care?
Yeah. So the concierge model does not scale to everyone. And it's not the sole model that's we're deploying to the market. And so you understand how complex the healthcare system is, who's really paying for care in this country, depending on the population, and we need to be as flexible to make sure that we are distributing care to like all people of color in the United States, including Black Americans, Latinx populations, South Asian Americans, East Asian Americans. So that's going to require different business models for different subsets of our population. So when we think about scale, we need to be flexible to sort of meet those challenges and make sure that as many consumers that want to access culturally competent care can, and that will include solutions that are accessible to employees of companies that we partner with, through payers that we have partnerships with, and some other populations as well.
Yeah. It's a tough challenge, right? I mean, I think we see this across all of healthcare, as you pointed out. It's a complex thing. Although I really love the combination of using your subscription model to also create an education platform that could have a wide-ranging impact across all of healthcare. So, really impressive vision. I appreciate you taking the time to share some of these ideas and perspectives, and hopefully, make me a little more culturally competent as well in our audience at Healthcare IT Today. So thanks so much, Dan, for being here. And thanks everyone for watching. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com. Thanks, Dan.
Thanks, John.